So today's agenda, I'll start off with a brief introduction to interpretative commenting, which is a recap of what I have spoken about before. I'll try to keep it brief, but I think it's important to touch on those every time we discuss cases. So I was going through some cases to discuss within the endocrine area and realized that I can only cover one area of endocrinology in one session, so I'm going to keep to the adrenals. And just to remind you that I'm really discussing how to comment on these results. This is not a case discussion or didactic teaching about diagnosis. And I'm not going to talk about dynamic function testing. Again, really, there's not enough time to discuss that. So that will be another session going forward. So recap, most clinicians welcome appropriately applied interpretative comments on clinical chemistry reports. In fact, interpretative comments may improve patient outcomes, and pathologists and clinical scientists have a duty to add value to reports where appropriate, including through interpretative commenting. So comments may be appropriate when a management or treatment decision is indicated by the results, or a result is unexpected, or a specific question has been posted by the doctor, but it's not obvious whether the results provide the answer, or where a clinician has requested a test which they are unlikely to be familiar with. Formal interpretation should be provided by an appropriately trained and qualified person. Comments are more appropriate for general practitioners and junior doctors, but not always the case, as attain user requirements. Over-interpretation may be misleading. If unsure, better not to comment than to say something that's inappropriate. Possible components of an interpretative comment include the presence or absence of an abnormality and its degree or severity. Possible of the abnormality, diagnosis, prognosis, change in status, in serial results, and suggested action or follow-up. It's important to communicate with clinicians to get feedback about comments and agree on test protocols and diagnostic criteria. So interesting cases are really avenues for discussion with clinicians. Attending clinical meetings and grand rounds are also important for discussion and also for visibility of the laboratory personnel. So I'll start with this first case, a 29-year-old female who was in casualty early in the morning with the history of adrenal crisis. This is the electrolytes that the laboratory received. The question is adrenal crisis, and the electrolytes, do they fit with the question of clinical diagnosis of adrenal crisis? Adrenal crisis itself is a clinical diagnosis where a patient presents in acute crisis. Often they are hypotensive, their blood pressure has dropped, they may be confused, and they may have abdominal pain and nausea and vomiting. In fact, adrenal insufficiency can present with abdominal pain, nausea and vomiting, which can be misleading. And sometimes it takes a while for patients to be diagnosed with adrenal disease, whether it's acute presentation or chronic presentation. And non-endocrine doctors can sometimes be confused by the presentation. So that's another set of symptoms to consider. So we in the laboratory only received the history of adrenal crisis on the request form, which is good enough, and these results are in keeping with the history of adrenal crisis, hyponatremia, hyperkalemia, bicarbonate at the lower end of normal, which suggests that the patient may be going into acidemia. Urea is slightly raised, urea and creatinine are slightly raised. Urea especially is often raised in adrenal disease and adrenal crisis. There may be volume depleted. So we often don't comment on electrolytes, especially in emergency, ICU, or general medical wards where the doctors usually know what they're doing, and usually there is a consultant in charge. Of course, if a question is asked, we can comment on it. We wouldn't have commented on this, but if the question is asked, we could say the hyponatremia and hyperkalemia, low bicarbonate, are in keeping with the with adrenal failure. Of course, the specific test for the diagnosis of Addison's is cortisol, together with ACTH if necessary, and available, and Renin. So adrenal crisis is an acute emergency, so diagnosis should be made clinically and management started without waiting for the results, although cortisol is can be done quickly in most core laboratories, and we have a 1 hour turnaround time for cortisol in our lab, whereas ACTH and Renin are not done after hours. They're batched assays. Certainly action shouldn't await those results. So these results, very low cortisol and a raised ACTH, are in keeping with the adrenal failure. Similarly, Renin is also very high. Very high Renin is often seen, always seen in untreated adrenal failure, because when there is adrenal failure, glucocorticoids as well as mineralocorticoid synthesis and secretion are reduced. So this is the comment. We would add the very low plasma cortisol with raised ACTH and Renin are consistent with the untreated primary adrenal insufficiency. Of course, these results confirm primary adrenal insufficiency, secondary adrenal failure. So pituitary is functioning well to secrete ACTH. Aldosterone should be measured to confirm deficiency. Of course, treatment shouldn't await measurement. It would be good if the sample is taken before treatment is started. Treatment often involves saline infusion, which is started straight away if the patient is hypertensive. Now, the cause of Addison's in Australia, in most Western countries, in most cases is an autoimmune disease, and adrenal antibodies, specifically 21-hydroxylase antibody, is specific to autoimmune adrenal failure, which is what Addison's disease is usually due to in our country. But it can be due to other causes like granulomatous disease or tuberculosis, which can affect the adrenals, or adrenal metastases from a tumor, or adrenal hemorrhage. These are less common causes. We would ask for adrenal antibodies to be done to confirm autoimmune adrenal failure. Now, this patient presented to our hospital many years ago, and at that time we didn't have the 21-hydroxylase antibody test. What we had was the immunofluorescence test for adrenal antibody, and even that gave a strong positive result consistent with Addison's disease. Okay, we will go on to the next case, a 34-year-old female with a of hyponatremia presented to the emergency department or presented to the hospital, and this is the history. They wanted to exclude Addison's. Cortisol was 110, which is below our reference interval, and ACTH was within the reference interval. It was low Renin. So what do these results mean? First thing to note is that the patient presented that night, it was 1:30 p.m. ACTH and cortisol have major circadian rhythm. So cortisol, in fact, decreases to half its morning value in the evening. Similarly, ACTH also decreases in the evening. So the reference interval here is certainly not appropriate for a sample that's taken in the evening. Other laboratories may have separate reference intervals for evening cortisol. We don't seem to have that. We just have a standard reference interval. It's certainly not appropriate. The other thing to remember is that cortisol methods vary. There's inter-method bias, and reference intervals are not harmonized at this stage for that reason, and so the reference interval is method dependent. The third point is that in an acutely ill patient, cortisol level goes up, of course, if their adrenals are functioning. And cortisol binding globulin is increased in patients on oral contraceptive pill or women who are pregnant, and the cortisol level goes up. So again, the reference interval is probably not appropriate for those cases. So those are the things to be remembered. However, what we would suggest is to repeat the measurement in the morning. So the serum cortisol of 110 at 7:30 p.m. doesn't really mean the patient has adrenal insufficiency. If the patient presented in the morning with these results, we would then think that these results are consistent, not diagnostic of adrenal insufficiency. However, the ACTH is towards the lower end, certainly within the reference interval. So what it does show is that the patient doesn't have primary adrenal insufficiency or failure. As we saw in the previous case, in primary adrenal failure, ACTH would be a lot higher. It's clearly above the reference interval and often very high. So primary adrenal failure is unlikely. However, secondary hypoadrenalism cannot be excluded based on these results. So we would suggest a synaptin stimulation test if they want to confirm secondary adrenal insufficiency. So that's the next step to do. I'm not going to talk about synaptin or other dynamic tests. That's for another time. So I will leave that for another time. The third case is a 42-year-old female with a history of central obesity. The doctor has queried Cushing's. Maybe there were other signs or symptoms of Cushing's, hypertension, diabetes, etc. However, the results are not in keeping with Cushing's syndrome, but in fact, it's very unusually low. The cortisol and ACTH are both unusually low. So the results are not in keeping with the clinical findings, and in most cases, one should certainly think about extraneous glucocorticoid, either doctor prescribed or taken in other medications. Now, certainly this is not prednisolone or hydrocortisone, because they they interact with our immunoassay. I mean, if it was a LC mass spec assay, then that would be different. This is an immunoassay. So it would be a steroid that doesn't cross-react with our assay, or it could be inhaled steroids or topically applied steroids. The complete suppression suggests that it has to be a high-dose steroid, and ACTH is also suppressed. So this is the most likely cause of these sets of results with the clinical findings, and might be useful to ring the doctor and speak to them to find out what's going on. This 73-year-old female presented to our hospital again some time back with pneumonia. Not clear why the cortisol was measured. The patient was in a high dependency unit, which is like a step down from an intensive care unit. We often get cortisol measured in intensive care unit patients for various reasons. Now, cortisol is often high in acutely ill patients, either due to stress or sometimes they in fact are receiving hydrocortisone infusion or some glucocorticoid medication which cross-reacts with the assay. So the value of 2000 really need to alert us to the possibility of drug interference. So that's the first thing we would want to say, because a random cortisol is not a very specific test for either adrenal insufficiency or adrenal excess. So we would first ask for ACTH to be added to the plasma cortisol once extraneous glucocorticoid has been excluded. The first thing to do is to make sure the patient is not on hydrocortisone or some other medication that can cause this cortisol measurement. And second, to check these measurements again with ACTH. And if it's confirmed to be raised, if the cortisol is confirmed to be raised, then we want to go on to screen for Cushing's syndrome. The three tests that are recommended for screening for Cushing's syndrome, so serum cortisol is not, the three tests are 24-hour urine cortisol, overnight dexamethasone suppression test, and or midnight salivary cortisol. So at least two of the three tests have to be positive for us to be reasonably confident that there's a possibility of Cushing's syndrome, which needs to be investigated further. So the next morning we received these tests with a normal ACTH and still a very high cortisol. So at face value, and we assume the patient was not on medication which could cause a raised cortisol measurement. At face value, this suggests ACTH dependent Cushing's syndrome. Now, if it was ACTH independent Cushing's, then ACTH would be suppressed well below 2.0, usually below 1, but certainly below 2.0. This is an ACTH within the reference interval, and a cortisol which is high, which suggests if it's Cushing's syndrome, it's ACTH dependent Cushing's syndrome. That's what you would think. However, then we found out that the patient in fact had received dexamethasone overnight. So this is really a post-dex cortisol. So dexamethasone suppression test was being performed. Now the ACTH is less easy to interpret after a post-dexamethasone test. The only thing we can say is it really confirms that this is not ACTH independent Cushing's. So if it was, ACTH would be low, and with the addition of dexamethasone, it would be even lower. So So what we would say is unsuppressed plasma cortisol is consistent with Cushing syndrome. So the reference interval is for random cortisol. For post-dexamethasone, overnight dexamethasone cortisol, we say cortisol should be less than 50 nanomoles per liter. So this is clearly very high, suggesting Cushing syndrome, assuming the patient is not on still on hydrocortisone or alternative medication. However, there are other causes for a false positive post-dexamethasone cortisol that doesn't suppress. I mean, the first thing to make sure is the patient did in fact take dexamethasone, and then exclude other causes for a false positive. Obesity, depression, and alcoholism are some of the common causes for a false positive. Don't want to go into detail investigating those, but this is clearly a positive test. So we suggested doing salivary cortisol, midnight salivary cortisol, or 24-hour urine cortisol. And salivary cortisol came back as 260, which is massive, because the normal range or reference interval for midnight cortisol in our assay, again, this is assay dependent, is less than 5.7. So the range you see in salivary cortisol is different to the plasma cortisol. In normal people, midnight salivary cortisol is well below 5.7 nanomoles per liter. So this is massive. And what we normally do is ask for salivary cortisol to be done at least twice, and if they're both raised, then that suggests Cushing's. Alternatively, you could ask for 3 consecutive measurements, and in this case, the repeat measurement also came back positive. So this patient, as you remember, presented with pneumonia, and they found a shadow in the lung, which possibly was a tumor, which was secreting ACTH. But before the patient could be investigated further, things took a bad turn. So we don't have a final diagnosis. However, this really is to discuss the principles of first-line management for the diagnosis of Cushing syndrome. Once Cushing's is confirmed, further investigation to differentiate between the different causes of pituitary-dependent Cushing disease and ectopic ACTH causing Cushing syndrome, or ACTH-independent Cushing syndrome due to adrenal cortical adenoma, carcinoma, etc. Are fairly specialized, and you would refer the patient to an endocrinologist for further investigation. So I will move on now to aldosterone and renin measurements. So this is a 49-year-old male who presented with hypertension, youngish male with hypertension, so the doctor wanted to exclude secondary causes, and aldosterone and renin were performed as part of the screen to exclude secondary hypertension. Usually we suggest excluding pheochromocytoma and primary hyperaldosteronism. And if there are suggestions, clinical suggestions for Cushing's, we would suggest excluding that as well. Now, the measurements are assay dependent again, so that need to be remembered. Our renin assay is a mass assay. So renin can be measured by immunoassay as a mass assay. Alternatively, in the past, we used activity assay, and I'll show you one set of results. It's probably a better functional assay, but labor intensive, so most people have moved on to mass assay. So because of the different measurements, inter-assay biases, the aldosterone-renin ratio, which is used as a screening test for primary aldosteronism, the ratio, the cutoff used as, for positivity is assay dependent and has to be lab dependent. So we use Aldo-Renin ratio of 50 as the cutoff. Now this is a screening test, so we are using a lowish cutoff to increase, improve sensitivity at the cost of specificity. So once 2 positive results are obtained on the same patient, we usually ask for 2 or 3 tests before we move on. If 2 or 3 tests are positive, or at least 2 are positive, then you work them up further, and I'll have to discuss that in the future. But the screening test is Aldo-Renin ratio. In this case, it's clearly normal. So this is what we normally say, an Aldo-Renin ratio below 50 indicates a low probability of primary aldosteronism, which is typically characterized by a renin less than 5 and aldosterone usually above 400. We sometimes see an aldosterone above 350, but usually it's well above 400. Not often raised, but in the upper half of the reference interval. And the aldosterone-renin ratio is 50, above 50. Now, as you can see, the posture is important. The reference intervals are slightly different for erect versus supine. Please mute yourselves. Thank you.
The students have to do it.
When,
Students have to do it. You don't have to.
Okay, so however, the false negatives are important in this situation. So hypokalemia can decrease aldosterone, and diuretics and certain antihypertensive agents, dihydropyridine, calcium antagonists, angiotensin II blockers, and ACE inhibitors can cause false negative results, causing an increased renin. So if the patient is on any of these medications, then you need to retest after the patient test, if possible, to cease the medication, and after 2 weeks, retest the patient. If it's diuretics, you need to cease them for 4 weeks. So that's a normal set of results, and this is the comment we add. But apart from saying this is normal, we also make sure that the doctors are aware of the causes of false negative or falsely normal results. So this is a 53-year-old female with hypertension. Here the aldosterone is quite low. I mean, it's still within the reference interval, but it's quite low. Renin is normal. Now you can see that the aldo-renin ratio is not reported. And the reason is when the aldosterone is very low, so if it's below 350, we don't calculate the aldo-renin ratio. The ratio is very much dependent on renin. So if the renin is very low, like in this case, even if the aldosterone is low or lowish, I mean, it's not low, but in the lower end of normal, you can get a falsely positive result for the ratio, which can be falsely misleading. So this often happens in patients with essential hypertension who have low renin hypertension. In the past, we used to call it low renin hypertension, where the aldosterone is low and the renin is also low. So if you calculate the ratio in this patient, it's close to 50, but it would be falsely raised. So we don't calculate if the aldosterone renin ratio, if the aldosterone is 350, because it's unlikely to be primary aldosteronism. Most cases of primary aldosteronism is characterized by aldosterone greater than 400, so that's what we say. However, hypokalemia can decrease aldosterone secretion and thus lead to false negative results. This is very important because aldosterone primary aldosteronism is often associated with hyperkalemia, and then the hyperkalemia decreases aldosterone. And so you can get a falsely normal or falsely low aldosterone in primary aldosteronism, and we've seen that in many cases, so we make sure that the doctors are aware. And if you have a electrolyte result on this patient, and we did have in this patient, and potassium was 2.2, and therefore we in fact put the comment that the patient has hyperkalemia, which can decrease aldosterone secretion and thus lead to false negative results. So we suggest a repeat measurement after the patient has been supplemented with potassium, and the potassium should be greater than 3.5 millimoles per liter before we retest the patient. So that's what we say, and we have seen a few cases which have given a falsely low patients with primary aldosteronism with the falsely low aldosterone due to hyperkalemia, and when the potassium is corrected, they give a positive result. So this is a 66-year-old female with malignant hypertension. Aldosterone is 439 and renin is 2.4. So as you can see, we have given 2 reference intervals because the posture was not recorded. We asked the phlebotomist to record the posture. So what we say is when a patient arrives, they have to be put on a bed for 30 minutes if they want to do it in a supine state, or otherwise record the posture as erect. In a hospitalized patient, it's easy when they're in the bed. You ask them to be in bed for at least half an hour when you bleed them. So if we don't know the posture, we give both reference intervals, but we assume that the patient has walked in and therefore is erect. And here the aldosterone is again within the normal intervals, and which is often the case in primary aldosteronism, but the renin is quite low and the ratio is clearly raised. So the ARR is consistent with the diagnosis of primary aldosteronism. However, need to be aware that there are a number of medications, hypertension, used for treating hypertension, beta blockers, methyl dopamine, clonidine, can lower renin and lead to a false positive results. And again, we see these quite regularly. So this patient was retested after the beta blocker was ceased, and as you can see, the renin has normalized now and the ratio is normal. So this patient really doesn't seem to have primary aldosteronism. It was a false positive result due to beta blockers. Now this is a 58-year-old male with hypertension. Aldosterone is very high, to 2,610, and renin is in the middle of the reference interval. Now the ratio is high, above 50. However, as I mentioned, the renin is suppressed in primary aldosteronism. In this case, it's not suppressed at all. Most cases of primary aldosteronism have a renin of less than 5, sometimes up to 10, but certainly not 26. So in this case, a very high aldosterone and a non-suppressed renin can suggest secondary aldosteronism, and this is often the case in patients on diuretic therapy or spironolactone, which is also a type of diuretic anti-aldosterone. So secondary aldosteronism should be considered. If it's not medication, renal artery stenosis is a consideration. And we remind the doctor that primary aldosteronism, renin is less than 5, and despite the raised, which is misleading in this case, the patient doesn't have primary aldosteronism. This is really more likely secondary aldosteronism. So 23-year-old female with hypertension in pregnancy. with these results. The ratio is normal, but aldosterone and renin are raised. Need to remember that they're both raised normally in pregnancy, so it's a bit harder to interpret the results. We haven't really set up reference intervals for aldosterone and renin in pregnancy, but often it's raised. Both of them are raised. Now, aldosterone is raised partly because of the binding globulin. Renin is raised due to increased prorenin activity. So really difficult interpretation. Now, finally, just an old case, old in the sense of several years ago, 32-year-old male presented for family screening. I'll tell you what for in a minute. Low potassium and high bicarbonate, which you often see in primary aldosteronism. So this patient has a high normal aldosterone, but see the renin. Renin is not a mass assay, it's an activity assay. So this was done many years ago when we had an activity assay, and the reference intervals are quite different. And so we report it as nanograms aldosterone per second per liter, which is the amount of aldosterone produced. But basically a very high renin and a high normal aldosterone. The ratio is really not significant at all. And again, see the ratio is very different because of the different assay, the cutoff. So this patient had a family history of Gittelman syndrome. So these results are in keeping with Gittelman syndrome. Now, Barter syndrome and Gittelman syndrome have similar biochemistry, not all biochemistry, but certainly electrolytes and aldosterone, renin, and they are genetic disorders that lead to abnormal sodium chloride handling in the renal tubules, leading to increased aldosterone and renin, and biochemical picture which is similar to primary aldosteronism. I don't want to go into detail now. Some specialized centers will have genetic testing also now for Gittelman syndrome and Barter syndrome, but just an interesting case. So I'll move on to pheochromocytoma and metanephrine. So we measure plasma-free metanephrines in our laboratory. We measure these by LC mass spec assay. We also do urine metanephrines, urine fractionated metanephrines, but we recommend plasma-free metanephrines as the most sensitive test for screening for pheochromocytoma. So this is a 49-year-old male. You may remember that case where they screened for secondary causes. Again, the same patient had a metanephrine and normetanephrine, which are within the reference interval. So that's the comment we make. A normal plasma-free metanephrine result makes secretory pheochromocytoma unlikely. Because of the close to 100% sensitivity, a normal result basically excludes pheochromocytoma. There are some rare pheochromocytomas which are non-secretory. They will not secrete, obviously, and can be missed, but most cases of pheochromocytoma will be picked up by a screening test of plasma-free. This is a 55-year-old female with difficult to control hypertension, and normetanephrine is raised, and metanephrine is not. Now, remember the reference interval here is slightly different to the previous case, so 49-year-old. So we have age-related reference intervals for normetanephrine, normetadrenalin, whereas metadrenalin reference intervals are the same across the age range. The other Important factors: patient must be fasting. Patients, again, should be supine for 30 minutes prior to collection. That's when these reference intervals would be appropriate. If they're not fasting and if they're being ambulant, then the measurement would be higher and you get falsely raised levels. They're usually only slightly raised, but they cause confusion. We get a large number of marginally raised norepinephrine or methanol, which then need to be worked up to define whether they indicate pheochromocytoma or falsely raised level. So the comment we add to mildly raised, and I would consider this mildly raised norepinephrine, is that pheochromocytoma is not excluded. About 20% of patients with pheochromocytoma have borderline elevated metadrenaline concentrations. I'll come to the definition of borderline elevation. However, there are other factors which can cause mildly raised metadrenaline: caffeine, non-fasting, as I mentioned, and number of medications, or stress. And so acutely ill patients, certainly if a patient is in ICU, their metanephrines are often raised. So what we say is repeat measurements, making sure the patient's fasting and supine and rested, and also any possible interfering medication to make sure that there is no false increases. So borderline increase, we say, is above the reference interval, and that 660 is for the young adults, up to 2,190 for norepinephrine and up to 1,200 for methanephrine. So that's roughly 3 to 4 times upper limit of normal. This is based on published data as well as our experience. So the patient had a repeat test after following our request to repeat, after ensuring that there are no interfering circumstances. So pheochromocytoma are not excluded. Again, 20% of patients with pheochromocytoma have borderline elevations. So what do you do next? We would normally make sure that the patient is not on medication that can cause interference, and then suggest a chlorinating suppression test. Now, chlorinating suppression test is useful only when the norepinephrine is raised. It doesn't suppress methanephrine, so that needs to be had in mind, and this is the case here. So that would be the next step for us. I'm not going to go into that today, but and that again then becomes a fairly specialized area. We would suggest endocrine supervision for chlorinating suppression tests. So another 57-year-old female with borderline elevation in norepinephrine and methanephrine. However, in this case, the patient presented with an incidentaloma. Now, an incidentaloma, when you say an incidentaloma, it means an adrenal incidentaloma. If an incidental finding of a mass in another tissue or another organ is described, then you would then define which organ it is. When you say incidentaloma on its own, it generally understood it's an adrenal incidentaloma. Now, a borderline elevation in metanephrines is quite significant when the pre-test probability is high. So when there is an incidentaloma, the pre-test probability is high, and borderline increase is quite significant. It has to be taken seriously. Of course, you have to make sure the patient is not on medication can interfere with the test, but we say borderline increase in metadrenaline concentration is significant in the presence of an incidentaloma, suggests endocrine referral. So about 1/3 of patients with borderline elevation in metanephrine's and an incidentaloma, in fact, have pheochromocytoma. The other group of patients who have a high pretest probability are patients with a family history. It can mean multiple endocrine neoplasia type 2. So if there is a family history of known to have a family history of MUN2, or if the patient is being monitored, then we take a borderline increase quite seriously and make sure that that's followed up with further testing. And as I mentioned, chlorinating test is one way of ensuring that the patient is either positive or negative. Now, more recently, we have added 3-methoxytyramine to our methanephrine profile. Now, 3-methoxytyramine is a dopamine metabolite. So methanephrine is adrenaline metabolite, norepinephrine is noradrenaline metabolite, and methoxytyramine is a dopamine metabolite. Now, dopamine is important for the diagnosis of paraganglioma, so it's quite important in children who are often present, when they present with this syndrome, present with either paraganglioma or a neuroblastoma. So dopamine measurement is important, or dopamine metabolite. But again, dopamine or its metabolite is often increased due to diet. So when an increase of this degree is seen, especially only with 3-MT, we ask for a repeat measurement after avoiding all the dietary factors which can cause a false increase in dopamine or its metabolite. So a repeat test was clearly normal in this case. Normal results makes pheochromocytoma or paraganglioma unlikely. So this is a urine methanephrine test in a 40-year-old male with hypertension and Parkinson's disease. So different reference intervals. So we do 24-hour urine collection. Methanephrine and norepinephrine were normal. 3-methoxytyramine was sky high, and this is often seen in patients on levodopa therapy. With levodopa is metabolized to dopamine and to 3-MT. But this degree of increase is really only seen in, especially in adults, only seen with levodopa therapy. Diet doesn't cause this degree of increase. We would ask for, well, best to check with the doctor if the patient's on levodopa, but with a history of Parkinson's disease, it's obvious the patient must be on levodopa, which can interfere with the test. Now here is a 73-year-old male with severe hypertension, and here you can see both metadrenaline and normetadrenaline increases in plasma metanephrines of this magnitude are typical of pheochromocytoma. And these are the cutoffs which we use, 3 to 4 times the upper limit in an older person. This is normetadrenaline is double the upper limit of normal or above, and this is clearly raised. There are some medications which can push these results into the 4,000s. Otherwise, this is almost diagnostic of pheochromocytoma. Once the levels go above those high cutoffs, we usually ring the doctor. However, this is the other side of what we have to check out. So the normetadrenaline is 3,700, clearly in the diagnostic range, but if the history of schizophrenia clearly is a red flag, significant increase consistent with pheochromocytoma. However, some psychoactive medications may cause falsely positive results. 3,000, 4,000. If it's above that, then it becomes even more likely it's due to pheochromocytoma. Review medication the patient was on clozapine, and so often you can't really cease the medication in these patients, and we have to assume that those medication induced unless the clinical features are very very indicative of it, very strongly indicative of pheochromocytoma, when you might really want to investigate further. Here, of course, they ceased the medication, a real case here, and the results normalized. So thank you. I'll stop with that. I think we've got about 5 minutes for questions. I'm happy to answer any questions that I know the answer to. Thank you very much.
Thank you so much, Dr. Sam. So if you have any questions, you can type it into the chat, or you can unmute yourself and ask directly. We have 1 or 2 questions already on. The first question was whether you have any textbook. I assume it means a textbook. Can you suggest any textbook or material for people who are interested in reading further to have more of this background?
Okay. The online resource that I use is called Up to Date. It's one word, up to date. It's now widely available and widely used. It's like a textbook, but it's really available online. So if you can get hold of that, that's really what most doctors use here. But specific conditions and tests, there are published guidelines and published review articles. The Endocrine Society, the American Endocrine Society website has published guidelines and review articles. So that's a useful resource. Again, you have to go online. I personally don't use textbooks anymore. We all go online, and the Endocrine Society is very good. They often have their guidelines available online. So it's just called the Endocrine Society, which is the US Endocrine Society, and their website has most guidelines which are needed, alternatively up to date.
All right, thanks, Dr. Sam. We've been getting some comments about the recording and the slides. I just wanted to comment that we will have the recording and the slides being made available on the APFCB website. And if you are registered, you will receive a notification when these are available. We have 1 question about the reference range for the Renin aldosterone ratio. I think there was a little bit of confusion because some of your slides had less than 50, and then there was 1 slide with the history of Github that said the reference range was less than 4,000. So I was just wondering, Dr. Sam, if you can just comment on that again.
Yeah, they're totally different assays. So the current assay that we use is an immunoassay for both aldosterone and renin, and these are the reference intervals. So if you note the renin reference intervals, the aldosterone reference intervals are also different in the other, but here the renin values are between 4 and 46. And look at the units, milliunits per liter. It's a mass assay. So that's what we currently use, but this is a very old case, and we used to do renin by activity and look at the units and the reference intervals, which are 0.3 to 1.2. So an order of magnitude lower. The aldosterone was somewhat similar, not quite the same. It was a different immunoassay, but the renin was an activity assay. So that's the reason why the ratio is different. So the ratio will be dependent on the assay that you use, and you have to work out what assay you're using and what units you are using. I purposely showed this to raise the issue of working out the ratio and the units depending on the assay that you use and the technology that you use.
Yeah, that's a great comment. Thank you. While we're on the Github slide, we have a question from Dr. Shrefan. She asked, "How do thank you for the great talk. How do you biochemically distinguish between Barter and Github syndrome?"
Yeah, biochemically, so the easiest way to remember is Barter is like someone who's on a loop diuretic, and Github is like someone who is on a thiazide diuretic. Calcium is different in these two. So patients with Barter syndrome have a high calcium excretion in urine, whereas Github urine excretion of calcium is low. Sometimes serum calcium can be raised in Github, but not always. So urine calcium excretion is probably the best test to differentiate the two. Magnesium may also be similar, different in the two. You have to put that together with the family history, and of course now genetic testing is available in some units. Aldosterone renin are similar. They show secondary aldosteronism, so raised renin and high normal aldosterone, so that they're not different.
I see. And just to clarify, when you said magnesium may also be different, this is urine magnesium?
Yeah, either urine excretion or serum. Urine excretion is probably the more sensitive test here.
Okay, thank you. So we have one more. I mean, we have many questions, I think, still on the group chat. So, but it's 2 minutes, 1 minute, two, maybe one more question, and then we'll see where we are. So the next one was, how do you determine the minimum level of aldosterone to report the ARR? Example, like in your lab, 350. So I think the question is about reference range, probably.
Yeah, that's a good question, and it's a difficult question to answer. So we used to say, we say that primary aldosterone is usually about 400. So we used to not report the ratio if the aldosterone was less than 400. Then we found that we might have missed 1 or 2 cases of primary aldosteronism by defining the cutoff at 400. So we reduced it to 350 now. Most cases have, cases of primary aldosteronism have, in our lab, aldosterone above 400, but 1 or 2, especially because aldosterone is sensitive to potassium level. So if the potassium is close to 3.5, and we say don't interpret the results if the potassium is below 3.5, but if it's close to 3.5, then the aldosterone creeps down. So to increase the sensitivity, we now report ratios about 300, aldosterone about 350, but by increasing the sensitivity, we are probably losing specificity. But what we say is the aldorenin ratio is a screening test. It's really not a diagnostic test. We say do 2 or 3 tests, and if it's positive in at least 2, then you go on to dynamic tests, and the dynamic function test we use a saline suppression test to confirm the diagnosis. So for a screening test, you need a high sensitivity, or assay with a high sensitivity, or a test with a high sensitivity. So that's why we reduce it to 350. This is really something we defined by trial and error. So we started with 400, now we reduced it to 350. Now this is assay specific. So if you, to mention the method, we use a liaison assay. It would be different for, it could be different for different methodology. So you have to work that out.
Okay, thank you. So we are at 5:01, but we have 2 more questions left in the chat. I don't know if Dr. Sam, you would like to just get to them if you have
Okay.
more time. Yeah.
Yeah, let's see one
Okay,
at a time.
then we do a hard cutoff maybe at 5 or 10 too. Next one is, do the lab need to offer both plasma and urine methanephrine tests?
No, you don't need to. If you have to choose, plasma is certainly the better test, more sensitive and similar specificity. The problem is plasma-free methanephrine is a much more difficult assay to set up. So we use LC mass spec for both. Urine concentrations are higher, so easier to set up. For plasma, plasma is free methanephrine, so not the bound, but the free, whereas the urine is the bound. It's a total, but fractionated. So the names are a bit confusing, but so yeah, plasma is the better one, but more difficult to set up because we need a much higher sensitivity, or a more sensitive machine, as well as expertise to set it up.
And next question is, does beta blockers affect the kidneys? And does it also affect the levels of creatinine?
Not to my knowledge, no. Beta blockers don't. Yeah.
Okay. Great. And so one more question sneaked in. What is the best test for diagnosis and monitoring of neuroblastoma?
Yeah. So in our lab, in our children's hospital, they still use urine catecholamine. So we in fact offer it just for the children. So they ask. I mean, it depends on what your clinicians want. So they still want urine catecholamines, including we measured so adrenaline, noradrenaline, dopamine, as well as HMMA. We have talked to them about moving over to urine metanephrines, but really they haven't got enough experience with urine metanephrines, which includes 3-MT. But so our pediatricians are convinced that urine catecholamines, including dopamine and HMMA, is the best way to go for their pediatric population for neuroblastoma. Certainly, urine dopamine is very good, and they also use HMMA. So we offer the full screen just for the children. Yeah.
Okay. Great. Okay, so we've gotten to the end of our questions, and we're also at the end of our time. I wanted to thank so much Dr. Sam for his time and effort putting together this amazing presentation. So many cases, and we also have a feedback form which you will soon receive a link to by the email. So we would appreciate any feedback that you might have. Dr. Sam, would you like to wrap up? Say anything?
Thank you for the organization, and thank you for your attention. Thank you to the audience. It's good to connect with you through the internet, and so we would like to continue offering these webinars about once a month. Next month, Prof. Ken Sikaris from Melbourne, many of you know his name, will be presenting on reproductive hormones, and then next year we will continue on. So in your feedback, let us know what else you want us to do. So with the endocrine webinars, we will continue doing other areas of endocrinology, as well as dynamic function tests, but it might take maybe 2 or 3 sessions to do all of that. Let us know what other areas, and we've had some feedback, but any more feedback would be welcome. Thank you again. We appreciate connecting with you. Bye.
Yes, thank you so much to everyone, and yes, do sign up for our next webinar on the fertility testing, which will be held, I think, on the 2nd of December. So if you haven't managed to get access to that that registration link, please do just reach out. Thank you so much to everyone. Yes, I see a question about certificate of participation. Yes, for those who fill out the feedback form, we will be providing a certificate of participation. And the feedback form will be emailed to everyone who registered. So, actually, Dr. Sam, while we are still on, I realize we have one more last question from Dr. Banerjee.
Yep.
Let me see, I lost the question. He asked, what preservative do you recommend for urine methanephrines?
Yes, I can easily look that up. We've got so we use sulfuric acid for preservation. Yeah, sulfuric acid.
Great, thanks so much, Dr. Sam.
Yeah. Thank you.
Yeah, thanks everyone for your participation. I will end the meeting now, and I look forward to seeing you at the next one, at the next masterclass. Thank you so much.